National Health and Medical Research Council. Delivered by an international consortium of partners, the focus of the project is to undertake a randomised controlled trial to test a novel healthcare intervention during pregnancy and the first year after birth. The ultimate aim is to provide policymakers, healthcare decision makers and health service commissioners with a cost-effective, evidence-based healthcare intervention to help prevent maternal and child diabetes. Throughout the project, these regular forum meetings will bring together policy and health stakeholders around a related topic or challenge. The topic for discussion today is understanding gestational diabetes, risk factors, screening and clinical practice. We hope to not only raise awareness of the project, but to also gather stakeholder input, get to know one another and exchange information of mutual interest. Joining us today, we have international stakeholders representing academic, intermediary organisations and regional health representatives. Before we get started, there is always some housekeeping to run through. So just to make you aware that for our future reference, this webinar is being recorded and transcribed. The recording will be publicly available after the event. Could all participants please remain muted unless invited to speak, but please do leave your cameras on if possible, especially if you are speaking. You will be able to ask our speakers questions after the presentations are finished, and we will also open up the floor to a more general discussion. If you'd like to ask a question, then please do use the chat function to put your question into, or you can use the raise hand emoji when it comes to the question time. You can also use the like function in the chat if you see a question that somebody else has posed that you would be interested to hear answered. And then we can prioritise those more popular questions if we do become limited on time. And please do use the chat function for any other comments or observations that you may have throughout the forum. The aim is that this is an interactive, informal networking event. It doesn't always feel as easy when it's a virtual event, but I'm sure we'll all get involved and make the most of it. So please do use this session to raise any questions, share your experiences and your knowledge, and to introduce yourself to your fellow delegates. So today I am pleased to welcome 3 presenters from the Bump2Baby and Me project. Each presenter brings different insight and knowledge related to today's topic. Firstly, I'd like to introduce you to our project coordinator, Professor Charlene O'Reilly from University College Dublin. So over to you. Thanks, Charlene.
Super. Thanks a million. Oops. Now, I think I have control. No. Sorry. There we go. It started. So firstly, I think the key thing is I'm here to talk about the risk factors for gestational diabetes and clinical practice. So in terms of why do we need to look at this, for those of you who aren't aware, gestational diabetes is the expression of elevated blood sugars or high blood sugars during pregnancy, and in essence they fall under a big umbrella which we call hyperglycemia in pregnancy. So gestational diabetes, I think this picture speaks eloquently to the point that it is a big health issue from the perspective of the mother, but it's also associated with a lot of other things that can influence the health of both the mother and the baby around the time of birth. But we also know that it has implications for longer term health. So in terms of when you think about the complications, there's things like cesarean delivery, birth injury, the baby can have high blood sugars or low blood sugar, should I say, lots of insulin present in its blood, and also things like respiratory distress when the baby's born. So we obviously want to avoid complications like that around the time of birth. But clearly, in terms of gestational diabetes, it's something that nobody really plans for when they get pregnant. And for example, in Ireland, we've got about 7,000 mothers-to-be that get affected by complications in pregnancy, such as gestational diabetes. So, for example, in the National Maternity Hospital, where we are the main site for Bump2Baby and Me, They have about 8,000 births a year, so that means that staff experience about 20 newly diagnosed cases of gestational diabetes in a week. Internationally, the rates are actually even higher, so it's 1 in 7 births. 1 in 7 births, and it can be even twice that, so 1 in 3, 4 births in some Indigenous populations experience gestational diabetes. Then when it comes to those longer term complications that I hinted to, 1 in 2 women are at risk of developing type 2 diabetes within 5 to 10 years of having had gestational diabetes. And it's about 8-fold compared to a woman who experiences pregnancy without having had the hyperglycemia. And the rates of diabetes conversion are higher in people who come from a non-Caucasian or white background and have higher weights. And speaking of higher weights, we know that the rates of gestational diabetes, as I said, are growing in women who are of a higher weight category, but also in terms of women coming into pregnancy, we now know that about half of women coming into pregnancy are in the higher BMI categories. But it's not all doom and gloom when it comes to having gestational diabetes. Clearly, we know that there's a very effective intervention around diet and physical activity, and that, as you can see, is quite effective at reducing a woman's risk. So there are plenty of risk factors that exist for developing gestational diabetes, of which I just mentioned having a higher BMI, but clearly there are other ones. So unfortunately, blowing out more candles is a risk factor, as is coming from different backgrounds, as I mentioned. So things like Southeast Asian, coming from African, Caribbean or Black backgrounds, the Middle East, as well as Indigenous or Aboriginal populations. But having had a previous history with gestational diabetes will increase your risk or likelihood of having another one. So about 1 in 3 for somebody who's from a Caucasian background, and it can be 1 in 2, roughly up to 1 in 80% chance of reoccurrence in some populations. So quite high depending on where you're from. And having had a previous baby that was large for gestational age, as we call it, is another risk factor, as is things like family histories of diabetes in your immediate family, polycystic ovary syndrome, and then there are some medications which actually increase your likelihood of developing diabetes in its totality, and so they're listed there as the known risk factors that we'll try and look for in mums to try and better identify them early on. So what do we do in current clinical practice in terms of gestational diabetes? Well, there's actually a lot of variance, so it's like kind of you get to pick which sweet you want out of the bag in essence, because the types of gestational diabetes or diabetes you can have in pregnancy are varied. And as you can see here on the slide, the one we're really interested in is the hyperglycemia that occurs first time in pregnancy, but you can have people who had diabetes coming into pregnancy. So there's different categorizations, which doesn't exactly make things easy for women. So for gestational diabetes, as you can see there over towards your right, there's early gestational diabetes and standard gestational diabetes. So in essence, you have 2 types mainly to worry about. And then when you think about it, you think, well, surely it's going to be very straightforward to actually get diagnosed if we know that there's those 2 types and overall it falls under one umbrella. Well, actually, there's an awful lot of ways with which you can actually do the diagnostic test. And that for some women is quite challenging, and also for policymakers very hard to get their head around, you know, which test am I actually using? So you can see there, this is not all of the diagnostic criteria in terms of the test itself. You can see you can do a 1 hour, 2 steps, 1 step. It sounds like a dance procedure. So in essence, it's not only the type of test that we use. As you can see here in this picture, the goalposts tend to shift for actually the women experiencing the test, because you might have gestational diabetes being diagnosed in one particular way using a cutoff, as we call it. When you look at a blood sugar value, you get a value, and the goalposts may shift from one hospital to another because certain hospitals may actually use different diagnostic criteria to say, yes, you have hyperglycemia in pregnancy, or no, you do not have it. So that can be quite challenging to actually work with. And then finally, I suppose looking at the care pathways that women experience, it can be quite varied. So it will vary at the level of different hospitals, as I mentioned. So for a lot of the times, they do tend to roughly categorize women after they've had their blood test, no matter which one they have, into being at lower risk versus higher risk, depending on how high or how low above the cutoffs the women actually are. So typically, if a woman falls into that lower risk category, they'll be managed with diet, which is modifying the amount of sugar or carbohydrate that the woman consumes, and doing exercise. In the higher risk categories, it's typically managed with medication, and that medication can be metformin or insulin. And typically the woman attends much more appointments in her care system before delivery, and then after delivery, as I said, it is simply hyperglycemia in pregnancy. For the vast majority of women, the diabetes in essence goes away after delivery. So here what you can see is whether or not women can be tested in that early pregnancy phase versus a late pregnancy phase. And it is very varied. So, but what you can see is sort of a common thread for most guidelines, is actually more than this, is that the unit of testing or the type of testing usually is informed by doing a bit of selective screening based on those risk factors that I mentioned previously. And one example of a really sort of hot off the press study, which is potentially going to influence care going forward, is one called Toboggan. And this is about treatment of gestational diabetes through the early booking visits, in essence. And so what they did in this large randomized controlled trial is they had about 800 women split into two arms. One received the early treatment straight off the bat before they were about 20 weeks pregnant, and the other received usual care, which is the more standard treatment that I mentioned in that slide. And what they were able to see is the women that got the early compared to the late had less complications in their babies. They didn't see any other significant impacts in terms of the maternal outcomes or even longer term sort of baby composition measures. But it's still, they think, going to influence perhaps how we look towards treating early versus treating late. So I think that's really important to bear in mind. And for this study, they actually still used that selective criteria to engage women. So the other challenges that we know exist for mums once they're diagnosed is that there's an actual big cost to say things like the the daily testing strips that they've got to use. And it can be, for example, around or higher than about €25 a week. So being out of pocket over the 12 weeks that you might have your standard diagnosis is about €300, and that's over a short period of time. As I said, the screening is not only varied, but it's also inconvenient. If you do a 2-hour glucose tolerance test, which is relatively standard across the board in different countries, you have to drink a very sugary drink, come in fasting, but then also sit for 2 hours and not do anything. So it's not usually very handy, particularly if you don't live near your hospital. There's a lack of national registers, so we don't actually know how many women have had gestational diabetes in a lot of countries. And also, when COVID was there were actually a lot of variations that happened on top of the normal ones in terms of how screening was delivered. So what it means is that women that were diagnosed in pregnancy may not be diagnosed again because the criteria were varied, or it might mean that there's higher rates. But finally, I suppose the other key thing is around COVID presented a bit of an opportunity in that there was a lot more health being taken up over the course of care. So that means that in terms of looking at gestational diabetes, we want to avoid those poor pregnancy outcomes and also longer term ones, and we want to promote health for diabetes prevention in both the mother and child going forward. And so that I want to leave you at is a case of saying that pregnancy itself we see as being a real window of opportunity that's going to offer a chance to women to establish their engagement with health services, to improve their long-term health, and also prevent that intergenerational transmission of those non-communicable diseases that we so want to avoid within health systems.
Brilliant. Thank you, Charlene. That was a really interesting insight. So yeah, over to you, Anna. Sorry, let's just change my screen there. So yeah, I'd like to introduce Anna Davies, who is a research fellow in health psychology at the University of Bristol. So thanks, Anna. Just on mute, Anna.
Sorry, thank you. So as many of you may know, the Bump2Baby and Me trial aims to support women with risk of gestational diabetes from the start of their pregnancy. And as part of our implementation work package, we were tasked with looking at and understanding current care pathways in each of the Bump2Baby and Me countries to try and inform future implementation of the intervention. So I want to give you a bit of a whistle-stop tour of the data that we've collected today in 3 of the 4 partner countries. So thankfully, Charlene's given a good introduction to understanding a bit about GDM screening and management. As she's mentioned, it's a really common pregnancy condition. It affects between 8 and 24% of pregnancies in the UK and Ireland, and around 15% in Australia. And the reason that there's a big range in the estimates of prevalence is due to variations in the way that people are tested. So this has potential serious consequences for the mother and baby, as discussed. There's an increased risk of stillbirth and a large baby, which can cause complications during delivery, such as shoulder dystocia. There are neonatal, potential neonatal complications, including hypoglycemia, which can mean that the baby needs a NICU admission when it's born. And also these future complications that we've talked about, increased risk of type 2 diabetes for both the mother and baby, and increased risk of obesity in the offspring as well. So it's absolutely vital that we try to prevent development of GDM, but also where it is present, we identify them effectively and treat them. So there's no need to look in detail at this table, but again, Charlene's touched on this, that there are variations in the guidelines used to identify and manage women with gestational diabetes. So just looking at this table, you can see that different risk factors are used across different countries. And the other thing to highlight is that even though a guideline in place in a country, it might not mean that that guideline is applied exactly in each setting. There may be variations to guidelines made locally in relation to the local population, things like clinician preference and resource. So the aim of our research was to try and map the context of current GDM screening practices, diagnostic practices, and also the care that women receive during and after their pregnancy. And as Charlene mentioned, because this was all taking place during the COVID pandemic, we wanted to try and explore the impact of COVID-19 on people's care practices. So we carried out a multinational survey of healthcare professionals in 3 of the 4 Bump2Baby countries, so in the UK, Ireland and Australia. And that survey was developed iteratively with lots of input from each of the sites to try and understand a bit about the context there so that we could ask the right questions. And we shared that survey out through national professional networks and also through direct relationships with staff and snowball sampling. And we had pretty good participation in the survey. Just looking at these maps, you can see the major cities in Australia and the UK were represented. And in Ireland, 12 of the 19 maternity units there participated. So first, looking at who is screened for GDM. Well, first we looked at the guidelines that were used. And as you can see, in each country, the units typically use their national guideline. However, notably in Ireland, there was use of other guidelines than the HSE guideline. And in COVID times, there was increased use of other guidelines, which was the generally tended to be the uptake of the Royal College of Obstetricians and Gynecologists guideline that was developed for use during the COVID pandemic. The next thing we looked at is whether all women were screened for gestational diabetes in early and late pregnancy, or whether it was a selected group of women. And you can see here on the left-hand side in early pregnancy, so at the end of the first trimester, typically selected women were screened, although there was a small number of units in every country that reported that they carried out universal screening of all women. You can see then on the right-hand side, later on in pregnancy, there was an increased use of universal screening, particularly in Australia and Ireland, but within the UK, it remained a selective screening process. Now, Charlene's touched on lots of the risk factors that can predict whether a woman might develop GDM. So just looking at this graph shows us the risk factors that we use to select women to be screened for gestational diabetes in early pregnancy. And you can see the main risk factor that was used to determine whether a woman was screened was previous GDM, so where she had GDM in a previous pregnancy. You can see in the UK there was limited use of other risk factors compared with the other two countries. However, later on, there was increased use of varied risk factors across all three countries. The most common ones were previous GDM, BMI, ethnicity. In some units, age over 40 was also used as a risk factor, and a family history of type 2 diabetes. An interesting thing to note in the middle here is that previous macrosomia, so a large for gestational age baby in a previous pregnancy, was also used as a risk factor. But the cutoff used vary between units and between countries, with the most common weight for the baby being greater than 4.5 kilos. So then we looked at how women are screened, so the blood tests that we used. Most typically, the glucose tolerance test was used here on the left-hand side. However, that was typically the most common test in the UK. However, there was greater variation in the type of test used to determine whether a woman had GDM in Ireland in particular. In the right-hand side here, you can see that there was increased, that the glucose tolerance test was also commonly used, but then there was reduced variation of other tests at that time point. So these are the tests that we looked at for women who were being diagnosed later in pregnancy, and the women on the left are those with previous GDM, and on the right without. So again, the glucose tolerance test was commonly used, although there was more variation in the tests used than in the previous graph. And in women without previous GDM, the GTT was the most common test used. This graph here shows which guidelines were used to diagnose women with GDM, and during normal times, the diagnostic criteria that we used to identify who had GDM were typically NICE in the UK and Ireland, and the ADIPS guideline in Australia. During COVID, there was much greater variation in which guidelines were used to diagnose it, with increased use of the UK Royal College COVID-19 guideline in sites in the UK and Ireland. So now going on to have a look at what care is offered to women who have GDM. So we first looked at what medications women are offered, and in Australia and Ireland, insulin is typically offered as the first-line medication in many units, and this is contrasted with the UK, where we typically offer metformin, which is ubiquinide, as the first-line treatment. Although you can see again that in Ireland there was more variation than within the other countries about which was the first-line treatment. In terms of the other care that women were offered, around 20% of units indicated that they offered dietary advice, blood glucose training, medication, and growth scanning as standard. In the Australia and Ireland, physical activity advice was also offered, but this was less commonly offered in the UK. And then on the right-hand side here, we can see that during COVID, there were changes to how women were cared for, and these typically were characterised as remote care, including remote monitoring of blood sugars, remote education, although there was less remote initiation of medication. In women who were managed with lifestyle modification alone, which indicates that they had uncomplicated GDM, births typically occurred between 39 and 41 weeks. In women who were using biguanides, so that's metformin, induction of labour and section typically was offered between 38 and 40 weeks. And this shifts a little earlier in women who are taking insulin, presumably as their diabetes has been more difficult to control. So in women with uncomplicated type 1 and type 2 managed using insulin, delivery is in line with guidelines at around 38 to 39 weeks for many, but earlier in more complicated patients. So now looking at what postnatal care is offered to women with GDM. A smaller number of people answered these questions. However, notably, most follow-up was conducted in the community in the UK and Australia, so that would be in GP practices. But in Ireland, it was more common for a woman to return to hospital to have her blood glucose testing in the maternity unit. And in terms of follow-up care, in Ireland, it was common to offer a postpartum education programme either in the hospital or outside. In the UK, many services indicated that they offered no postnatal care. In Australia, follow-up was typically offered via GP services or via postpartum education. So what does this mean for women and for the Bump2Baby research? So what we found is that there's considerable variation in the care pathways that we've identified. And ultimately, this indicates that for women, it's somewhat of a postcode lottery as to whether they might be diagnosed with GDM, what treatment they might be offered in terms of medication and lifestyle-related support, and what care they might get after their baby arrives to try and prevent some of these long-term poor outcomes. So altogether, this means that there may be some variation in the clinical impact of having GDM for the mother and baby, both during the pregnancy and postnatally, according to which country she lives in, but actually indeed which maternity unit she attends. In terms of the BUMP trial, then, these findings provide us with some contextual understanding of how to look at the effectiveness of the Bump2Baby and Me intervention. There's potential for variation in the intervention's impact between sites because different women might be diagnosed with GDM, and also the care pathways that those women might be offered may differ. So this will help us have a think about how we can implement the Bump2Baby and Me intervention following the trial. Thank you very much.
Super.
Brilliant, thank you. That was fabulous, Anna. Really interesting work that you've been involved with, and we appreciate you sharing that with us today. So now it's back to you, Charlene, for a quick overview of the trial. Thank you.
Thanks a million. So in terms of the Bump2Baby and Me study, obviously, as was highlighted by Anna, we're really trying to look towards prevention. So rather than sticking right in the moment, we're trying to look at both the mum and the baby into the future. So the Bump2Baby and Me project has a large amount of partners, as you can see there. It's a 5-year study across 9 universities, as well as expert groups being involved. And over the 5 years, we're looking to design and deliver an evidence-based intervention that will help prevent maternal and child diabetes, also overweight and obesity, when delivered within antenatal and postnatal settings. So in terms of it as a study, obviously, what does the study involve? So the Bump2Baby and Me is an mHealth intervention, so we need the women to have a smartphone, but in essence, health coaches are trained to provide the support for a woman at the time when she wants it through use of things like personalised goals, weekly push notifications, and helping the mum to think about how she's progressing with those goals, as well as providing a library of information that the mum can actually use. For anyone who's interested, we have published the RCT protocol for that, if you can get a lot more detail in that paper. So as I said, those trained coaches will work with a mum from birth, right the way through birth, should I say. They're not going to be working with them while they're giving birth, right the way till the mum has a 12-month-old. and they'll personalise the content for every mum so that she's receiving hopefully the right information at the right time for her. So within the study, obviously this is a screenshot of what one of the screens within the app looks like that Leva Healthcare support us in delivering. And as you can see, there's things like goal setting is embedded within it, and we've tailored them to each life stage. And we also have those individual library content pieces that, again, we've developed for mums both in pregnancy and also after they've delivered. And they're very much focused on the woman's needs and at each of those stages. So we have an intervention that happens over those 18 months roughly, and it has 5 main features, you know, in terms of the app to help support the mum as they move from that pregnancy period right the way through to having a little baby that's running around in sort of crawling terms at 12 months. So the synchronous coaching happens at 2 main sessions. Then there's also asynchronous coaching, which is where you have text messages delivered and personalised to the mum. They happen at a regular basis all the way through pregnancy. And we also have automated push notifications in terms of messages that are delivered at set periods as well. So the mum's really getting quite a holistic package, and they can also access, as I said, those library of resources at any time, and they're also tailored to what stage the mother is at. And then finally, there's also a virtual social network embedded within the application where mums can talk to other mums that are experiencing the same issues around the same time. So where are we at now with the study? In essence, as I said, there's 9 partners overall, but as you can see, the clinical sites are those in green. So we have Dublin, Bristol, we have Granada in Spain, and then Monash is the clinical site over in Melbourne in Australia. Here's just a quick screenshot if those are the hospitals for anyone who's interested. And we're going to have 800 women with about 200 per site. And it means that we have about 2 health coaches as well per site. So in terms of the study design overall, we do that risk factor screening, and we use a tool that was developed by Monash University, one of our partners. And once women score 3 or higher on that tool, then they in essence have a 30 to 40% elevated risk of developing gestational diabetes, and they can be invited into the randomized controlled trial. They're then randomized to either intervention, which is our usual care plus the app and health coaching, or control just receives usual care. And as I said, that's the 18 months that it happens over. So in terms of our participant progress overall, as you can see, this was taken just at the end of last month. We've made quite reasonable progress through everybody. And so we've a lot of women that have finished. So we've 637 women who've completed out all of the study. And we have obviously those sort of roughly about 86 spread out over the 4 countries that are due to finish up, a lot of them in this month in Europe. And for Australia, they were a little bit slower getting started because their COVID rates were higher at different times. So we're flying through, and it's hard to believe that we've gotten that far, but it's very, you know, positive for the study overall. So for the study overall, obviously we started in 2020. And we recruited our final participants in 2022 at the very start. And then clearly for Australia, we'll be finishing out in September of this year. And we should anticipate to have our full results from that kind of primary outcome paper in and around January of 2024, which is very exciting. So clearly the intervention is designed to give women reach more women at the right time, and to also reduce the health service burden through implementing something through routine service delivery. And the study is going to contribute hopefully to early prevention of maternal and child overweight, obesity and diabetes, as well as other NCDs. So in terms of the data, we have different data coming out at the moment. Towards the end of September, October, November, we should have the data coming out from the postnatal visits in every site, and then that will allow us to next year deliver the cost information as well as the policy impact components. So I think that's, you know, as I've said, that January is going to be our next period. And just to highlight to anybody who hasn't already visited, we do have the Bump2Baby and Me website, where there's an awful lot of information, and we do update it with any news and events, as well as any publications as they happen. So it's a nice place to go, or to at least follow. And as you see down the bottom, we're also on Twitter, and we're quite active on LinkedIn as well. So I'd like to pass back.
Thank you very much, Charlene. So now to introduce our final speaker for today, Maeve Youngman, who is a research assistant at University College Dublin. Thanks very much, Maeve.
Thank you very much. So as you've heard from Charlene, the Bump2Baby and Me trial is designed to be part of routine antenatal care. And I am just going to be talking about this very first step, which is the identifying of women at risk of GDM in the foresight. So within the trial, we are screening women for risk of GDM. This is not a diagnosis of GDM, which we've heard from the others. So this is risk screening. We use the Monash GDM risk screening tool. It uses routinely collected, non-invasive information, which is collected in the hospital setting or by phone if it's over COVID. And these include risk factors for GDM. So they include age, body mass index, GDM on a previous pregnancy, and family history of type 2 diabetes as well. So these are all risk factors that you've heard previously. And according to a review carried out in 2020, it was found to be the first trimester prognostic model for predicting GDM diagnosis. So the Monash GDM risk screening tool works, the way it works is for each category, you get a score of either 0, 1 or 2. For age, if it's 25 years or younger, if the person's 25 years or younger, they get a score of 0. For 25 years to 34 years, they would get a 1. And for 35 years and older, it would be a 2. For a body mass index of under 20 kgs per meter squared, they would be a 0. For 20 to just under 35 kgs per meter squared, it would be a 1. And for 35 and over, it would be a 2. If they had not had a previous GDM in a pregnancy, they would get a 0, and if they had, it would be a 2. For a first-degree family history of type 2 diabetes, they would score a 0 or a 2 if, sorry, it's actually a 1 if it was family history of GDM. Sorry, that's just a small error there. The ethnicity, so Caucasian scores a 0. If they were from Black or African American, maybe Middle Eastern, Asian or South Asian ethnicities, it would be a 1. And Southeast Asia actually scores 2, so that's Vietnam, Cambodia, Thailand, all of those. All of these are then added up, and you usually get a risk score between 0 to 9. And as Charlene mentioned before, you need to have 3 or above, and that's indicative of a 30 to 40% increased risk of developing gestational diabetes. Okay, not sure what's happening here. So of the 5,613 people who were screened at the 4 participating hospitals, only 4,447 were actually screened with the Monash GDM risk screening tool. And of those, we had 1,828 who were not eligible. So they would have scored 2 or under on the screening tool. So we had a total of 2,456 who did score a 3 or more. And that led us to a Monash GDM penetration tool rate of 55. That's just, and then they were screened with additional study criteria, which led to an eligibility for the trial of 1,806, which gave a total study penetration rate of 51. So of those people who were eligible for the study, we invited 1,555 to the study. And of those that we invited, 865 accepted the invitation, which gave us a participation rate of 48%. So now we looked at all the site differences were reviewed. Yeah. So Melbourne reviewed the most people with 2,193. That was followed closely by Bristol with 1,553, and then Granada, and then Dublin actually reviewed the least people with 770. Some of the people were actually excluded pre-GDM, pre-Monash GDM screening tool, so they weren't actually screened. So half of the Melbourne site weren't screened with the tool, so that the people that were actually screened with the tool, the most were Bristol with 1,548, followed by Granada, and then Melbourne with 1,032, and then Dublin. Of the people who are not eligible, it was quite distinctive. So we had 51 between both Bristol and Granada, both had 51% who would have scored 2 or less with the GDM rescreen tool. So Dublin was close with 44%, but Melbourne only had 15% who were not eligible. So they had scores, mostly they were 3 and higher. So just looking at that now. So of those who were screened, we now have total GDM penetration. This is of 82 for the Melbourne site. That was followed by Dublin, which was 56, and then Granada 49, and then Bristol 41%. And after study criteria was screened for study criteria, we then had quite a change. So Melbourne actually dropped down to 31%, and that was followed by Bristol with 38% penetration, and then Granada was 44%, and then Dublin was 54%. So of those who were invited, we had, this was quite close, so we had Melbourne had the highest the participation rates with 66%, followed by Dublin with 61%, and Bristol with 55%, and then lastly Granada with 45%. So just to conclude, looking at the screening data, there was good penetration across all the population, but it did vary between the countries quite significantly. But then participation rates were high and similar between the countries. Okay, thank you.
Thank you, Maeve, and thank you once again to all of the speakers for sharing your knowledge and information this morning. I would now like to open the floor to any questions for our speakers, and also just to invite a general open discussion. So I'm just going to stop sharing so we can see each other and see if we've got any questions in the chat. Okay, so there's no questions in the chat. Has anyone, you can raise your hand if you have a question. Okay, so Joe, you've got your hand up.
Sorry, I'm jumping in as a project person. I was just wondering whether we've any idea whether some of those changes that happened during COVID have kind of gone back to normal now, or do we have any idea whether that, or do you think some of those kind of changes have stayed? Anna, it's probably something I don't know whether you can answer.
Yeah, I can certainly answer some of that, and it's only really from local experience. As we mentioned, everyone went on to remote monitoring, so a lot of people took up remote monitoring, particularly of blood sugars, and also interactions with diabetes specialists, midwives and nurses. I know from our local experience, it was actually really galvanised our hospital, and actually we've heard from colleagues as well, to start taking up these remote services, and it's something that everyone was really happy that it happened quickly, So certainly we've remained using this app called GDM Health, which supports women to monitor their blood sugars, and it can feed that data straight to their specialist nurses, so that there's they can be monitored remotely rather than having to go in and be looked at, and got rid of the paper diary. So certainly that appears to be staying as long as budget allows.
I can also echo what Anna said in terms of care for the mums. Dublin in the National Maternity Hospital were one of the first in Ireland to switch over to those electronic monitoring, and it was one of the major successes. So they had much higher attendance because we obviously, like most hospitals, have big catchment areas. So for the mums who were located in other areas, we found that there was a geographical drop-off in attendance for appointments. So because the National Maternity Hospital is located right bang in the middle of town, it's actually hard to get to, particularly if you live further away. And they had much greater uptake in care and engagement in it. And so obviously it's helping meet the needs of the mum as well as anyone else's within the health services.
Oh,
thank you.
I've just seen a question for me again.
Yeah.
Thanks, Aisling. Well, what we're hoping to do is actually write a policy brief about some of these findings, which is in progress at the moment. So it's going to be thinking, I think, especially about how we get people taking up the best evidence-based practice and adhering to their national guidelines, because we can see there's this variation. And I guess we need to understand a bit about why people are varying from the guidelines, to understand, what the barriers to that might be, or if they need to be incorporated into the guidelines to take account of risk factors that are maybe not being, certainly in the NICE guideline at the moment, there's some risk factors that are being used in other countries that we're not using. So I think it will be interesting to see how we can look at that data and incorporate it.
Yeah, and I suppose in some ways the culture within the different health settings is something that is hard to unpack. Clearly in Ireland we're a small country, so it's quite common that we would use the guidelines that other countries produce, because we don't produce a lot of our own. So I think that speaks to some of the variation that we saw in Bump2Baby and Me, was that Ireland in essence we're very much a can-do attitude when it comes to finding guidelines. If we can find one that suits us, we'll find it elsewhere. But it can create a bit of a challenge, because it means that if you go to one Dublin-based maternity hospital, you can be diagnosed a different way to somewhere down the road, and so that's clearly not great for the women, but it's also not great for the system as well, because you can't rely on it being consistent between even geographical areas, so it's hard to actually administer the care.
Yeah, interesting. We do have another question from Nina asking, do you have any information on the fathers? Is that something that's been thought about?
So we do have information on not in relation to the parents' health early on, but we do have the opportunity for the partner to come along to the exit interviews that we have at the end of the study, to give their perspective on the experience that the mum had, but also in relation to their experience if they were in the intervention arm, what it was like to be the partner of a participant. So that's the level of data we're collecting. We're not collecting health data per se from partners.
Okay, brilliant. Hopefully that answers your question, Nina. Is that the perspective you were thinking about? Don't know if she's there. Okie doke. So there's no other questions in the chat. Was there any other questions, Jo, that were pre-submitted?
Not at the moment. I think Aishling's just added another add-on one.
Sorry, yeah. So Aisling, thanks for that. It says it's interesting that the risk of GDM was different across the sites too. Was that expected in the trial?
I can give a short answer. I don't know if Maeve wants to give a longer answer, but no. It's actually something that we're quite interested in getting our heads around, because in essence we took what was the best available tool, and it appears that we are seeing geographical differences between Australia, which is where the tool was developed. In terms of the data that they've pulled together, perhaps it is very geographically important to understand, because you could see so many of those risk factors have differences that you might expect to go between countries and populations. So I think it's something that we're very interested in unpacking a bit more in the study, because we were hoping that we would have a nice relatively standard distribution, but we didn't actually see that, even though we all screened roughly the same amount of women. You can see that there's different national flavours coming through in the types of women that for their risk, as well as their geographical, where they were located.
I just pop in to say I did actually look at some of the factors that might have contributed, and the Melbourne branch had higher amounts of women who were in the ethnicity, so of category where they would score 2 or higher, where when I looked at the Dublin site, we actually, in the control arm at least, we actually didn't have anybody in that category at all. So there was a difference there. I'm not sure if it would have made much difference, but they are more diverse. They do seem to have a more diverse population over there. Yeah.
Brilliant, thanks. Okay, so Nina said that going back to the question on the fathers, I hoped you had information on risk factors from the paternal side. Another question, I can see the follow-up of the offspring ends at 1 year. Do you plan to continue follow-up at a later age of the offspring? Thanks, Nina.
Yes would be the nice answer. Clearly we want to monitor the long-term health of both the mother and the child, and potentially, incorporating information from the wider family unit if you can. So yes, but it requires funding to actually go back out and contact the mums and babies and get them back in for further sort of screening as they age. But we would be very interested in following them up, because clearly it's important to know what those longer term benefits are for further research.
Brilliant. So another question, are the study participation rates typical for this kind of trial? Is that indicative of whether women should take up the intervention in the real world?
So no, they were actually a lot higher than is to be expected. So I believe the rates are usually more around 20 to 30%. So we did actually have extremely high rates of participation, especially for such a long study, 18 months. So yeah, so we had good participation rates. Yes.
Yeah. I mean, I've gone back and quickly looked at the numbers. So, for screening in the wider populations, you could roughly expect that from getting somebody screened right the way through to actually taking up the app part of the intervention, or the intervention or usual care part of randomization, you could expect that out of 120% would actually be brought through. So that's actually very high when you think about the normal conversions. Normally you see about 20 to 30% at the screening stage, not when you've actually got them right the way through to actually taking part in something. So it was quite positive to actually see that of all the women screened, you were getting still quite a lot that were eligible, but also taking up the study when it was offered to them.
Yeah, excellent. Did you have your hand up there, Joe?
I did, but I'm just conscious of time. I was just wondering whether that was going to be unpicked about why that might have been a higher penetration rate, whether it was the COVID pandemic, whether that's something that's going to be picked up with the 12-month visits as to why they may have been more keen to take part or not. But I'm conscious we need to wrap up soon, so.
Yeah, I mean, I think it's interesting. I think that the low burden in essence of doing just risk factor based screening as opposed to ones that require, say, blood results or anything that's a bit more invasive, makes it a little bit more amenable to being done, particularly during COVID, but also in just normal routine care period times. But I think it speaks quite nicely to the fact that, I mean, I know they're not very accurate, but risk factor based screening does help the woman acknowledge what her risks are, and having that initial conversation appears to be something that there is an interest in, because once the women were aware that they were at higher risk, then they were willing to do something about it. So I think from a health service perspective, it's quite interesting that once they've had that conversation, that mums are actually wanting to engage in potentially something that might help them in the longer term. So actually doing the screening is something that we also know is not consistently done across countries, and that's why some countries, as I would have shown you with the kind of mixed bag of types of testing, there's universal screening where everybody is offered the test versus selective, and that difference seems to mean that we get a drop off because people forget. We're all very busy when you're working in practice, and remembering to do your screening tool or to think about risk factors is one more thing that somebody needs to remember. So we're humans, we're not machines, and we tend to find that that's not consistently done. So I think it's nice to hear that when it's done, women have an appetite and an interest in engaging in self-care.
Thank you.
Okay. Okay, so we are out of time, so I do need to wrap things up for now, but thank you for all your questions and for the discussion, and just a few concluding remarks. So going forward, we would very much like for you to keep in touch with the Bump2Baby and Me project. So you can do this by firstly completing our event feedback form, and there's a QR link on the screen there, or also we will put a link into the chat if you prefer that method. We really appreciate your feedback, and we will use it to shape future events to make sure they're of value to you. On that note, please do attend our next forum, which will take place on Wednesday, the 23rd of November this year. And the topic of discussion will be behaviour change. It's more than just willpower. So it should be a really interesting event. You can also follow us on Twitter or LinkedIn, or you can sign up for project updates and policy related developments via our website. You can see the link there on the screen. So finally, I'd like to say a big thank you to our speakers and participants, and we look forward to the next Bump2Baby and Me Forum, and enjoy the rest of your day. Thank you very much.